Hey everyone, just wanted to go over some content for this week, for week 5, for HSAM 6360. So we're going to review its chapters, I believe, 9, 10, and 11, which is consent, death and dying, and patient-assisted suicide, or patient-assisted, physician-assisted suicide, and autonomy. So consent. I'm not going to go over everything in the chapters. I just wanted to hit some of the highlights to hopefully help you have a better understanding of the information so that quizzes and discussions and all of the case studies will go smoothly. So it's kind of just an introduction to consent. When we think about consent to treatment, there's kind of different levels of consent. There's consent to treatment with regard to when you walk into your physician practice, typically for the first time, you'll sign a consent to treat form. And that's just general consent for the physician practitioner, whomever, to see you, to provide, to do an exam, those types of things. So there's that kind of level. Then there's kind of a couple of stepped up levels. And when we use the words informed consent, it does apply to all of them. But when you think about for anyone that's had a surgical procedure, the informed consent form that you receive before having that surgery lays out the risks and benefits, the potential complications, potential other treatments that could be provided instead of this procedure, and just a whole bunch of detail. And the purpose of it is it's grounded in that autonomy that we have. So we need to make an informed decision about whether or not we want to go forward with the procedure. So that's really what that is. It's all rooted in that notion of autonomy. There's another level of informed consent that exists for research. So if you're taking part in a research study, you're going to go through kind of the same things. It's going to talk about risks and benefits. It's going to talk about how your information will be used, whether you receive any compensation, all of these different things. So there's different levels of informed consent, but they're really just all rooted in autonomy, which is our ability to make decisions for ourselves. And we as Americans have the ability to make that decision generally. Not everybody does all of the time, but generally we have the ability to do that. If you have failed to obtain consent, if you're a provider and you have failed to obtain informed consent for a procedure or anything really where you're laying hands on a patient, it could be considered battery. So sometimes people get assault and battery confused, so I'll just talk about it quickly. But so assault is when you threaten to touch someone in a non-consensual way. So I always pick on Dr. Hampe and use her as the example, since she's right across the hall from me when we're in the office. So if I go into Dr. Hampe's office and I say, hey, I'm going to punch you in the nose, which of course I would never do, but hey, I'm going to punch you in the nose, that could be considered assault, because there's two pieces that you need to have for assault. There's the threat, and there's the ability to carry it out. So I'm an adult. I would have the ability to, and she's right there, so I would have the ability to punch her in the nose. So that would be assault. If I actually did punch her in the nose, that would be battery. So battery is the actual touching. Assault is the threat. So if I said, hey, I'm going to punch you in the nose, and punched her in the nose, that would be assault and battery. When assault is not part of it is when there's no threat, when there's just a non-consensual touching that occurs, or if the threat is not real. So let's say a 2-year-old, a little tiny child, goes into Dr. Hampe's office and says, hey, Dr. Hampe, I'm going to punch you in the nose. That's not likely to be, it wouldn't be considered assault. Because that 2-year-old probably couldn't punch her in the nose, couldn't reach her nose. So assault only exists if there's a threat and it's viable. Battery exists when the action is actually carried through. So why do we care about all this? We're talking about consent. If you are a physician and you perform a procedure or a service or lay hands on a patient without consent, that's considered battery. So you can be charged with battery, and that has happened a multitude of times in surgical cases where surgery was performed without informed consent. And it usually is rooted in some other malpractice or negligence related to the case. Um, Obviously, there can be negligence related to consent if the physician doesn't give the patient all of the information they need to provide or they need to decide. So um, the if the informed consent is not detailed enough, doesn't provide the risk and benefits, doesn't provide alternative treatments, if they just don't give everything that you need to make your own decision, that can be considered negligence as well. And we talk, the textbook, and we've talked about it throughout the weeks leading up to now. We need to protect against paternalism. So, kind of that notion of the physician being the protector. We need to protect against that because it's not up to the physician to make a decision. It's up to the physician to provide the patient with all of the appropriate information and let them make a decision. Just like as we had talked about with what was it? The flu vaccine, the case study we had with the flu vaccine. It's up to the provider to give all the information and say, hey, here's all the information, and let patients make their own decision. However, they need to provide all of the information. And in our case study that we looked at, that person was looking to provide only their biased side of the information. You really need to provide all of it, risks and benefits, pros and cons, to patients. And that's why for our final project, I want you to look at both sides of an issue, because in the healthcare world, we always need to be looking at both sides. Even though we personally may agree with one side or the other, like vaccines is a great example. There are anti-vaxxers, there are pro-vaxxers. I personally vaccinated my children, but I myself don't get flu shots. Has nothing to do with fear. It has everything to do with the fact when I get one, I get the flu, so I choose not to get them. But if you're for vaccines, it's important that you understand the anti-vaxxers' backstory. Why do they believe that? If you are anti-vaccine, you need to understand the pro-vaccine side of things. And we're seeing a lot of that with herd immunity, and is that potentially an option once we get vaccines for COVID, et cetera. So it's important to understand not just what you personally feel, but in the healthcare world, as a provider, as an administrator, we need to understand both sides of the issue. We don't necessarily have to agree with them, but in our role as a healthcare administrator, we need to act morally and ethically, not based on our own personal bias. Okay, legal aspects. So we need to have consent that's voluntary. So a patient cannot be under duress. And one of the big issues with informed consent is if a patient is in an emergent situation, sometimes we can have issues with consent when the patient's under duress. So that's a potential issue. There are some rules and regulations surrounding consent in emergency situations that help to mitigate those things. But just from a pure ethical standpoint, there is the potential for duress to violate or to make a consent not voluntary. The patient has to be competent. So competency evaluation, and for those of you that do work in clinical settings, you know how difficult competency evaluation is, especially as people get older. Patients can be competent 1 minute and completely incompetent the next minute. So it's important that we have a competent person to make decisions on behalf of the patient, or make sure that the patient themselves are competent. Just a brief example, my father-in-law, who is in a nursing facility in upstate New York, there was a time when it was found that he had I think a DNR. It wasn't just a DNR. He had like a band on his wrist when we went to see him before we moved down here, or one of the times we had gone back up. It was like, don't do anything for me. Like, his wishes have always been, kind of not 100% clear, but it just seems that he would want things to be done for him if it got to a point where someone had to make decisions on his behalf. And this wristband he had on made it seem as if he didn't want any of that. Spoke to the social worker on his floor, and she said, "Oh no, I don't have any idea where he got that from." And they didn't have any documentation of his saying that those were his wishes. But the issue that we discussed with her is that he's not competent. He has dementia, doesn't have the ability to make decisions on his behalf. So that's not up to me, it's up to my husband. But the patient needs to understand and have competency to make decisions of that nature. And informed. So we've already talked about informed, risks, benefits, other alternatives, potential complications, that kind of stuff. There's kind of two different standards, and this is where that paternalism can leak in here again. So the one standard is the patient should get as much information as a reasonable physician would provide them. So, here's what would be the norm, the standard for that particular type of consent. The other standard is the patient should get as much information as they want. So all the information they can take. There is a notion called therapeutic privilege, and therapeutic privilege does allow doctors to withhold info from patients if they feel that it's in the patient's best interest. So instead of bombarding, let's say, a newly diagnosed cancer patient, going through informed consent for chemotherapy treatment, and there's 400 other different options that they could, and hopefully they had a good discussion about all of this, and this isn't just a form being filled out, but there's tons of other options. Sometimes, due to therapeutic privilege, a doctor will narrow what's available, the information available to the patient, just because it's in their best interest. It's far and above what we can manage as a layperson to sift through, and it's not even for those that are lay people. Sometimes healthcare providers on the patient side of the world have difficulty, dealing with the new diagnosis, sifting through the information, figuring out what's covered and what's not covered, et cetera, et cetera. So that therapeutic privilege does allow physicians to limit information as long as it meets what a reasonable physician would provide and is in the patient's best interest. They can't do it just to hide something that they don't want to do or whatever. It needs to be something in the patient's best interest. And that relates back to paternalism. Our system has really, for many, many years, been based on paternalism, but law gives us autonomy. So there needs to be some balance there. So ethical aspects of consent. What is voluntary? So I've already talked a little bit about patients in distress. Is that voluntary? If a patient's in distress, it could just be that they're having a very stressful time because of a new diagnosis, et cetera. So what is voluntary? And there, as all of these questions, there really aren't right and wrong answers to most of these. There's tons of shade. There's no black and white, just lots of shades of gray. Patients with terminal illness, are they in a situation where they can make solid decisions? Maybe the patient prefers another option, but the physician feels that the first option is more appropriate. So there's, back and forth there. Bad versus good things. So if the patient's sense attitude from the physician about something being bad versus something being good, can that skew their views on consent to certain things? Some, and this is where paternalism comes in, some say that patients only have veto power. So in other words, they don't get to say, hey, I want to have this treatment instead. They can just say, no, I'm not having a treatment. So that can be a problem as well. Inducements are certainly can affect volition and be problematic overall in the consent process. Managers need to honor patient autonomy and decision making, but also honor the physician's knowledge base and the background that they're working with, both with the patient and with the disease process and treatments as well. Just a few more ethical aspects. Competence is assumed in adults a lot of the time, and that's not always a good thing. My father-in-law is a great example where for probably 6 months of his initial stay in the nursing facility, they were like, oh yeah, he's fine, he's doing great, that's just Ed, that's the way he is. But it really wasn't. That's not the way he was. That's what they knew of him, so they thought that was his normal, but it wasn't his normal. And it took us a long time to get them to understand that. If a patient's mental status is questionable, the provider, nursing staff, whomever it is that's involved in this, needs to seek consultation. So you need to make a determination of capacity. Is the patient, do they have the capacity to consent? Any policies that you have must state any type of assumptions about autonomy. So if you're making assumptions about autonomy generally in your organization, like if you're assuming all patients are competent, or if you're assuming the general signature that you get covers minor procedures. If you need to make assumptions in policy form so that it's clear what types of things are assumed versus what types of things need to be spelled out in a different consent form, etc. Informed versus adequately informed. So I can provide an informed consent with a small amount of information, but we really want patients to be adequately informed. We want them to have all of the information that they need. What would a reasonable physician provide in a consent? And that's what we want to see in our consents to make sure that they're valid. And some states require patients to receive that sufficient information in order to make an informed decision. And think about, you're making a decision for, I'll just say, a surgical procedure. You're making that decision is not only a healthcare decision, but it's a financial decision as well. So you need to make an informed consumer decision. You are a consumer buying that surgical procedure. So you would do research and look at different things. If you're going to buy a television, you need to apply that same autonomous thinking to your medical services as well. Okay, so that was the world's quickest run through of, of consent. We could talk for hours about consent, but we won't do that. If you have questions that I haven't addressed, just let me know. So we're going to talk about death and dying as well this week. Obviously, there's tons of ethical issues with relation to death and dying, providing palliative care, providing comfort care, tons of things that are made worse by the fact that we have made so many medical advancements over time that it postpones death. So we can keep people alive on machines forever, so where where do we draw that line? We need to make sure that we have better laws that govern these types of things. And make sure that if we are unable to make decisions, which if we are in that situation, obviously we would, that we have the appropriate information in place for our families and our caregivers to follow with regard to our care moving forward. So end-of-life type decisions are not just the purview of clinicians. Healthcare administrators also need to be sure that our organizations have the appropriate policies and structure within our organization for end-of-life decisions, for setting people up to be in the right position if something like that were to come up, those types of things. So one little distinction to mention before we go forward, life-sustaining treatment is also life-prolonging treatment. So life-prolonging treatment is really any type of treatment that'll prolong life, but is not reversing the underlying condition at all. So I can continue to hydrate someone, feed them through a feeding tube, keep them on a ventilator. It's not going to reverse, like maybe we think about the Terri Schiavo case. I don't know if we talk about Schiavo in this class or not, but she had brain damage secondary to what they think was probably a cardiac event secondary to bulimia. Ended up with pretty significant brain damage and or a circulatory event, I guess not a cardiac event, although I think she had a cardiac event as well. But so with her, she was non-responsive, fully on nutrition and hydration, artificial nutrition and hydration, and on a ventilator. And so that's a life-prolonging treatment. So it's certainly not going to fix the brain damage that she had. That's just a treatment to prolong her life. And there was a massive court battle that ensued. And like I said, I'm sure it's mentioned in the textbook because it's really a landmark case with regard to end of life. But it's important to understand that distinction. So historically, the cessation of pulsation, so circulatory and respiratory function, was the definition of death. In 1980, they also added whole brain death. So for whole brain death, there are three findings: coma or unresponsiveness, absence of brainstem reflexes, and apnea. So those three pieces feed into brain death. And brain death is endorsed by many medical organizations as a determination of death, etc. So when we see sometimes a patient has met the brain death, they're coma, unresponsive, lack of brainstem reflexes, but they're being kept alive on a ventilator or they would definitely be kept alive on a ventilator, but with also artificial nutrition and hydration, so that organs can be harvested. That's they haven't met that pure definition of brain death until all of those pieces line up. So sometimes that happens, and we're going to talk about advanced directives here in a moment. But this is why it's so important that we all have advanced directives, whatever is required in your state. Make sure that you have that. Make sure we're fighting this battle right now with my father-in-law, not kind of having an idea of what he would have wanted, but not truly knowing what he would have wanted, and it's difficult at best. As my husband and I have both said, we're going to be moving soon, but as soon as we get to that new location, we're going to make sure that we have advanced directives in place for both of us so our children don't have to go through this when we reach that point. So advanced medical directives came out of the Patient Self-Determination Act, and I don't know if we talk about that in the law class. Our law class isn't really a law class. It's more focused on policy. But Patient Self-Determination Act is really what governs autonomy in this country with regard to healthcare. So it governs the requirement for consent, the ability of us to make our own decisions, and obviously, as it says here, requires all the different types of organizations that participate in Medicare and Medicaid, which is pretty much everybody from an institutional standpoint, to have written information about their rights. And also within those rights, it describes your ability to accept or refuse treatment. One of the other things that it does mention is advanced medical directives. So it provides us with the ability to make decisions about our future care in advance. So things like, do you want to have artificial hydration and nutrition? Do you want to have ventilator care if you've reached a futile state? Do you want to have all extraordinary measures taken to save your life, etc. So there's a multitude of questions that we would talk about. So very few patients have them. Only about 1/3 of patients have them, and generally folks that are over 65 are more likely than younger patients. But it's important at any point. I could finish this. What is this? This is a video. I could finish this video. I could see I'm losing the capacity to consent. It's not a good thing to get old. So I could finish this video. I could walk outside and a car could run me over, and perhaps somebody would need to make decisions on my behalf. So it's not just the senior set that needs to have these. We all need to have them so that everyone's aware of what your wishes are. And sometimes your wishes change. I can tell you that my wishes now are very different than they were before I saw my father suffer and die with cancer. I don't wish that on anybody, and I certainly don't want to go through it myself. So my wishes are a little different than they were prior to that happening. And our wishes do change over time. If you put advanced directives in place when you have, maybe you're just recently married or you have a young family, they're probably going to look a little different than when you're 65. So it's important to not only make those, but continue to update them. Like make that a yearly thing or every 3 years or whatever to update that information. Joint Commission, many states started requiring it. Actually, New York State was one of the states that required hospitals to ask about advanced directives anytime they walked in the hospital. So you could be there for a lab visit, you could be there for an inpatient stay, for an ER visit, etc. You were always going to get asked about advanced directives. But since then, the Joint Commission has actually required it as well. So Joint Commission states that hospitals need to address wishes about end-of-life decision-making, withdrawing life-sustaining treatment, withholding resuscitation, and as they are listed here: CPR, intubation, dialysis, transfusion, artificial hydration and nutrition, etc. So hospitals need to be dealing with this proactively with their patients. There is a document known as a living will. So what a living will does is that it communicates to caregivers. So for example, I could do a living will and it could tell my son that this is what I want with regard to CPR, with regard to artificial hydration, nutrition, etc. And it'll give some really good and helpful information. However, living wills generally aren't, there's no legality surrounding a living will. It tends to be more of just a guidance document for your caregivers. And so patients need to rely on the willingness of their caregiver to actually follow it if you reach a point where you are unable to make decisions on your own. So what's important is that every state is going to have its own advanced medical directive law. So don't just write a living will that you found on, law.com or whatever, one of those legal form sites, and assume that that's accurate for your state. That is definitely not the case. You need to follow the format. Some states call it healthcare proxy. Some states actually call them a living will, but they're actually a specific form that the state has set up. Everyone has a law with regard to advanced directives, and some have penalties against caregivers. So me, like perhaps me and my husband with regard to my father-in-law, but also organizations for ignoring a patient's advanced medical directive if it's done appropriately, if your advanced directive follows the state guidelines. 75% of cases show that there's no documentation in the medical record that the physician consulted the patient's record for advanced medical directives. And once documented, the advanced medical directives influence decision in about 86% of cases. So if the physician gets that documentation in there that they have reviewed the advanced medical directive and here's what's stated and here's what the wishes are, that in a large percent of cases is influencing decision making for incompetent patients. So having that documented, doing the proper format for your state, and then documenting that is crucial. Fragmentation can make these types of documents tough to follow. So it's each state has different rules and the types of things that they're listing. So they can be a difficult thing. Determining mental status can be problematic. So, like for example, right now we could get on the horn with with my father-in-law and say, hey, what are your thoughts on this, so we can get things set up for you. But he is not currently in a state that would allow us to do that. So he doesn't currently have the capacity to consent or to really even to discuss those things with an answer that we would be able to use. So that's where you really need to think about these things far in advance of any time that you would need to use them. Studies have shown that patients are more likely to complete these documents if the hospital gives the information prior to admission. So if it's a situation where you have patients scheduled for surgery to come in, scheduled for some type of procedures, like infusion treatments, etc., these are great times for the folks that are working to get them set up for their admission to have this discussion. And actually, interestingly, I think it was either last year or the year before, the coding system that exists for coding of services, it's called CPT, CPT coding. CPT actually added, it's run through the American Medical Association, CPT added a code for people within a physician's office. So it could be clinical staff, it could be provider themselves reviewing the advanced medical directives with a patient. So kind of like a counseling session on advanced medical directives. And to be able to bill for this service, they don't even have to sign. They don't have to sign a advanced directive. It just needs to be documented that it was discussed in detail, not just like, hey, do you have one? No. Okay, let's move on. It needs to be in detail. But so there's a notion that by talking to people about it and providing them with the information, it really does encourage them to get these directives in place. So surrogate decision making is a situation where someone other than the patient is making healthcare decisions. And typically this is done through a power of attorney. So it can be there, and there's lots of different situations for power of attorney. Oftentimes, what we see in the healthcare world are durable powers of attorney. That my husband is a durable power of attorney for his dad, and so the surrogate decision maker is going to make decisions based, hopefully, on the information in the advance directive. So the advance directive has been put in place, and then the surrogate will make decisions based on that. So that surrogate decision making, the tool for that is the power of attorney. The advance directives inform the surrogate decision making. So when I make my choice for, I'll just use my mom for an example. She's in her 80s. I'm not a power of attorney for her, nor am I on her advance directives that I know of. So I'm not part of that process, but let's just say I was. Once power of attorney is given to me, if she gets to a point where she loses her own capacity to consent, then I would be, they would reach out to me to say, hey, we're doing that, we're going to do a surgical procedure. We really think it's going to improve her quality of life. It'll help her, it'll help prolong her life. She'll have better quality of life. We think the risks outweigh, the benefits outweigh the risks a great deal. And then I can make a decision based on that. But that's all based on the power of attorney process, not the advance directive. So the advance directive informs a surrogate decision maker. There are other formats, but power of attorney is the POA is the most common. Do not resuscitate orders, or DNR. You'll hear it referred to in the facility setting typically. So DNR is an order, an advanced medical directive that's used at the point of service. So point of service could be in the hospital, it could be in the nursing facility, it could be at home if you have an EMS DNR. So what it talks about is what can and can't be done with regard to resuscitation if you're found in a situation where you would need resuscitation. So it identifies chemical and mechanical technologies, instances when they should be applied and should not be applied. Typically, if it's a DNR, they're not going to be applied at all. And then you can have those EMS or emergency medical services DNRs. We typically tell patients to leave them right on the refrigerator, and it makes the patient's wishes binding in the home. So if I wish to not be resuscitated, and I have my completed DNR and it's on my, typically hospice patients will have that. It'll be like right on the fridge. Paramedics know to look to the fridge when they come in, and there it is. What's important about a DNR is that patients' wishes need to be clear. So what is the patient's wishes? Do they understand what a DNR means? And the managers need to, healthcare administrators need to make sure the policies and procedures are in place so that DNRs are appropriately followed. They're not given when it's not appropriate to give them, and that the patient's wishes are clear when that is being put in place. So euthanasia. Euthanasia is sometimes called mercy killing. This is not, we'll talk about physician-assisted suicide here in a couple minutes, but euthanasia is just a general term for actively causing someone's death in the situation of a mercy killing, not a murder. Although you can, if you participate in a mercy killing, you can likely be charged for at least manslaughter, but likely murder in most states. It is illegal, obviously, and it's really about hastening or bringing about death by increasing medication, those types of things beyond the amount needed for pain control. So if you were a physician and you gave a patient, 40 times the normal dose of morphine to kill them, for in the instance of a mercy killing, that would be considered euthanasia, but it would also be considered illegal in most states. So there are some patient-assisted suicide options, physician-assisted suicide options, which we'll talk about, but generally it is considered illegal. Artificial hydration and nutrition, we've talked about that a couple times, is considered ordinary care if there is hope of some benefit for the patient. So just withholding artificial hydration and nutrition, if there's a hope of benefit to the patient, we can't withhold that. If there's no hope of benefit and it's the sole instance keeping them alive, then that would be considered extraordinary care, and we do not have to go. We only need to hit the standard of care. We do not need to go above that. But if there is a hope of benefit of the hydration and nutrition, that does need to continue, and withdrawing that could fall within the realm of euthanasia. So ordinary versus extraordinary, we've already talked a little bit about this. It doesn't mean usual and unusual. It really means standard of care or above that. So the criterion is the hope of benefit as compared with excessive expense. If it's a very painful procedure, does the benefit justify the burden? So absent any hope of benefit, any type of a treatment or operation or medication is going to be considered extraordinary. So we need to make sure that the benefits justify the burden related to expense, pain, etc., prolonging life, without any hope of improvement, etc. So ordinary versus extraordinary, like I said, we've already talked a little bit about it, just a little bit more detail there. Types of euthanasia. So there's voluntary euthanasia, which is freely consented to. If I reach out to my provider, say, I have a terminal illness, my quality of life is horrible, etc., and we put something together, and I'm in a state where that's legal, that would be voluntary. Involuntary would be a situation where a person can't or hasn't freely consented to euthanasia. So sometimes, sadly, I think about we had to put our cat down in February, got very sick. Obviously, that was involuntary. It was a merciful act. One of the hardest things that people that love animals have to do, but it was involuntary. But it was still a mercy killing situation. It wasn't, we were trying to end his pain. He couldn't breathe. He had pancreatitis. It was a horrible situation. So it was appropriate, but involuntary because he was a cat. There are situations where family members will take that burden on themselves and see that in their family. Or whoever it is they're caring for, spouse, children, parents, etc., and they'll take that involuntary act to bring about the death of that patient. Active euthanasia is that there's positive steps in place to bring death, whereas passive is a more natural cause of the disease, exacerbated by something that causes that mercy killing. Patient decision-making process, we've already talked a little bit about this, but competent patients have autonomy, so we have the right to decide on all of those types of things with regard to care and treatment. Nursing facilities, hospices, and home health agencies are the types of organizations that really need to prospectively address these types of issues at end of life. These are the organizations that are going to be seeing, yes, acute care hospitals absolutely see patients that die, but percentage-wise, it's much lower than in a nursing facility, hospice, or home health agency. Generally, most people die within the care of those facilities, or those organizations. So you need to have those ethical issues addressed through your policies, and those policies need to be very clear to patients, staff, etc. I won't belabor the point, but we've had some very interesting and from the ethical side of things, uncomfortable conversations with the nursing facility that my father-in-law is at, where their organizational philosophy is not the greatest. It kind of seems like they're just waiting on him to die so they can put someone else in that bed. And that's certainly, if you are placing a patient in one of these facilities as it's your parents, it's, someone that you're giving care to, from a personal perspective, you need to look at that philosophy and see what their philosophy is with regard to end of life before you put them there, because we're seeing things about this organization now that we didn't see originally, and it's too bad. It's too bad. It's too late now to make changes, but it's sad. So it's important to make sure that we as healthcare administrators have a clear vision that involves an ethical and moral stand, and that our organization reflects that mission as well. And as patients and family members, we need to make sure that we're placing our family members in places that reflect our own personal, moral, and ethical thoughts with regard to that whole situation. Okay, one last section. Patient autonomy, physician-assisted suicide. I think this is chapter 11. We've already talked a bit about autonomy, but probably the bigger part of this section is physician-assisted suicide. So generally, the physician's role is really to care for patients, make them well, and to provide comfort always. So if you look at the Hippocratic Oath, it's going to actually prohibit giving a deadly drug or deliberately causing someone's death. But we do have states that allow physician-assisted suicide, which is a situation where the physician provides the means and the appropriate instructions on how to enable someone to commit suicide. But the patients themselves are the one that perform the act. Ultimately, the ultimate autonomy in that case, but the physician provides them with what they need to do. Physician-assisted suicide is legal in a very limited number of states. It really started in Oregon. I think that was really the big area where it started. This list of states here this list is changing regularly. I'm leaving this. This is what you see in your textbook. This is the list that we're going to work off of for purposes of our discussion. But there are changes that are made to this regularly based on policy. So I didn't want to make any changes because I didn't want to divert from what was in your textbook. But know that this can change and does change over time. Generally, polling has shown that the large majority of Americans favor physician-assisted suicide. And one of the most famous physicians that was involved in this was Dr. Kevorkian. He assisted in at least 130 suicides, and only about 25% of the patients that he assisted were terminally ill. Many of them were in early stages of degenerative disease like ALS, Alzheimer's, etc. So not person that has stage 4 cancer and has gone through all their treatments and doesn't have anything left. That was not always the case. You think about patients that have ALS or patients that have Alzheimer's. It can be a slow progression to a not a great quality of life eventually. So the majority of the patients that he was involved with were in the early stages of those types of illnesses. So the Oregon law was one of the first, and it permitted physicians to prescribe but not administer medications, hence the physician-assisted suicide. Patients have to be 18 years old, and they have to be Oregon residents. So it's not like you can just flock to Oregon to have this done. The law stated that the patient needed to have capacity, and they needed to have a terminal degree with 6 months, a terminal degree. Academia in my head. Terminal disease with 6 months or less to live. Other criteria were that you had to have 2 requests. You had to have a confirming physician, so another physician involved, and feasible alternatives need to be presented. So, here are other things to keep you comfortable during the remainder of your terminal illness, etc. The physician can attend when the patient is taking the medications, but they cannot administer them. And it's not required for the physician to attend, but they can if, for whatever reason they feel it's appropriate. In Oregon, Blue Cross and Blue Shield and Oregon Medicaid do cover these services. But there are a lot of concerns associated with it. When these first laws were passed, and now that's why I say that list of states changes, because people, a court will strike it down and then another court will say it's okay, and it kind of changes over time. Generally, the notion was that physician-assisted suicide was going to be used against people that were poor, uneducated, mentally ill, socially isolated, situations where it wasn't someone that has a terminal illness that we're providing euthanasia, that we're providing that mercy killing for. They were going to use it to cull people that they didn't feel were appropriate to be alive, which is obviously horrible from any standpoint that you would think about it, ethically, from a policy standpoint, from a legal standpoint. We can't do that. So there was that fear. However, these types of laws, these types of guidelines, potentially have led to improved end-of-life care, more effective pain management. So, okay, this option exists, but let's see what we can do to make things better for you to let this process run naturally instead of taking that option. It also provides the opportunity for physicians to talk more with their patients about end of life, what available options there are, etc. So this exists and is legal in some places, but it's highly governed, and there are other options, and physicians can talk with patients about palliative care, whatnot. Physician-assisted suicide, euthanasia, they don't always result in an easy, peaceful death. The medications may not work. There may be technical problems. There may be unexpected effects. Patients may take longer to die. They may end up in a coma, especially because it's medication related. You never know how a person's going to react to a medication. So it's important to remember that it's not like, oh, take these pills and all will be well, or I just think I couldn't stay in the room when we had to have Ernie put down, but my husband did. But it's you don't know what's going to happen, and I think that's part of it's not always just peaceful. Your loved one goes to sleep and that's it. The other issue with physician-assisted suicide is that sometimes the suffering is not just physical or is not terminal. So patient may just be tired of living. They may have a disease like ALS that they know is going to be very difficult as they age. So that suffering they're not physically suffering yet, and their disease isn't terminal. They just don't want to reach that point. So that's where there are really a lot of ethical dilemmas related to that. So what do we need to think about as a manager in a healthcare organization? That ethical difference between providing comfort care, pain control, palliative care, and hastening death through active intervention. Now, obviously, if you're here in Pennsylvania, which I think the majority of you are, it's not legal here, so you don't have to worry about it. But we really do need to think more about, as an industry, we need to think more about palliative care and end-of-life care. We just don't do a great job at that. If this is a topic you're interested in, Jewish Health Foundation does a death and dying fellowship program. The students that I know that have gone through it have loved it. Like if that's a topic they're interested in, palliative care, really, really great stuff. As a manager for an organization, you are the moral agent, moral advocate. You are the organizational conscience. So you need to set the tone for your organization from an ethics standpoint with regard to these end-of-life issues. And you need to make sure that you get buy-in from your staff, from your clinicians. Make it clear through your mission and your vision and your values and policy as to what the notions are for your organization. Economics of these types of procedures. When insurers cover physician-assisted suicide, there may be some duality of interest here. So reimbursement incentives through things like capitation and DRGs cause an inherent conflict of interest between what's the patient's best interest and our financial performance. So it's important that we work through those types of ethical dilemmas as well. Again, not an issue here in PA, but in states like Washington and Oregon, it certainly is. And they need to make sure that they're really working in the patient's best interest and not applying, not making decisions based on finances. Issues on the clinician side, really physician-assisted suicide turns medicine on its head. It really, physicians are here to save lives, not end them. And it can jeopardize trust in that relationship. When we talk about physicians and why they may not be interested in these things, they say it could fail, it could cause harm to the patient. The patient's prognosis may not be accurate. I think back to when my dad was diagnosed with cancer, he was told that he would live like 6 months, and he lived at least another 5 years, if not longer than that. And the majority of that time, he had a decent quality of life. So it's, the prognosis may not be accurate. They're not sure what drugs to prescribe. They don't want to be suicide doctors. They don't know, they don't want to be part of that. So certainly physicians don't have to be part of these things in states where it's legal. But I can see though those dilemmas, those ethical dilemmas that physicians face with regard to their entire being, their existence is to help save patients, to keep them well, make them well, and this is the complete opposite of that. So just in conclusion, with regard to the physician-assisted suicide stuff, laws that allow it do not necessarily establish a patient's right to assistance. It's all about all of those criteria. So if you meet those criteria, you may be eligible. There are some concerns that these types of voluntary euthanasia will become more accepted. And it might reduce ethical issues for the physician if it's an accepted part of life, but it can also raise greater issues for society where we may, euthanize people willy-nilly. Just, oh, well, that person, they don't have any family, they don't have anyone to care for them, so we don't need them. So we certainly don't ever want to get to a point like that. It really needs to be a very specific situation. The other side of that argument is, like the situation that we had with our pet, we have greater mercy on animals than we do on ourselves. And that's kind of the other side of that argument. We don't let our animals suffer if they're in pain and there's no help there, and it's medically futile. We generally don't let them suffer, whereas people, we do. And so that's the other side of that argument as well. I don't personally have a vested interest one side or the other. I'm so torn between both of the ethical dilemmas that I couldn't personally make a decision of that nature. The final point, managers need to assure that just because a patient has the right to die, which they do in some states, it doesn't mean that they have to. So there's no duty there. So if, it really needs to be based on autonomy, rooted in autonomy and in the laws that exist. If a patient meets those criteria, they have that right, but it doesn't mean that they have to take action on it. And that's the patient's decision in conjunction with their physician. So that's a lot of stuff, but that's all I've got. Hopefully this is helpful. We have a lot of material each week, as this was just a brief discussion of the material that we have for each week. But we are ultimately a 16-week class crammed into 8 weeks at the graduate level. So that's just the nature of the situation. If you have any questions on any of these topics, please let me know. But otherwise, I look forward to our discussion this week. And that's all I've got. So reach out if you need anything. Thanks so much.